This is the seventh and last video of the series Quality Improvement Workshop, in which we will describe a quality improvement project example through which we apply many of the principles of quality improvement described in this workshop. This workshop is made to train quality department staff as well as quality designees in different departments, in addition to hospital administrator and department heads interested in quality, that help them participate in quality improvement projects. For more videos, visit my Facebook page, Healthcare Quality. Our project is about improved patient transportation system. Memorial Hospital is a 350-bed acute care hospital serving a diverse urban community in a large city of the United States. Like many hospitals, it has had to deal with shrinking inpatient census and tight budgets. A few years ago, Memorial experienced a downsizing that reduces the hospital's bed complement from 500 to 350 and decreased the staff sharply. As a byproduct of the downsizing, increased burdens were placed on all the hospital operating system. Among those feeling the stress was the hospital system for moving patients from one place to another. Because the transportation system was not dependable, complaints about its performance increased tremendously. Stories abounded about 1 hour waiting time for transporters, personnel being lazy, and surely patients, staff, and physician dissatisfaction, and an inability to maintain department schedules because of the system was unpredictable. Committed to preventive as well as clinical care, Memorial recently adopted total quality management to improve healthcare delivery process. Its quality committee has commissioned a quality improvement team and has given it the following mission: significantly decrease physician, patient, and staff complaints about the hospital's patient transportation system. Questions: is the team's mission specific enough? Why or why not? Is this a good quality improvement project? Why or why not? What areas of the hospital should be represented on the team designated to solve the quality problem, and why? Who should be responsible for solving the problem, and why? In addition, the Quality Improvement Committee has given the team the following team charter: project reference, patient transportation system. Problem: complaints about the transportation system are frequent, yet downsizing, decrease in length of stay, and increase in patient acuity has increased the need for a more reliable transportation system. Mission: significantly decrease physician, patient, and staff complaints about the hospital patient transportation system. Expected output: identify the causes in the current transportation system that contribute to its unpredictability and implement solutions. Measure of success: decrease number of complaints. Constraints: present implementation plan to the Quality Council within 6 months. No increase in staff permitted. Minimize expenses of proposed solutions. Expectations and support: team members must make 8 hours per week available for the project. Monthly progress reports will be made to the Quality Improvement Committee. The team will follow the quality improvement steps embodied in the quality improvement training materials. A temporary employee will fill in for transporter participation in team meetings. Requests for existing data to information system or management system must be met within 3 days. Select a team. Memorial Hospital's team for improving the patient transportation system includes these individuals: Dan, the head of the transport department, team leader; Sally, a transporter; Fred, a vice president for operations, which includes the transport department; Grace, a nurse manager; Maria, manager of the radiology department; Joe, a nurse trainer as a facilitator. These people were chosen for several reasons. As a transporter, Sally has first-hand experience with the system and everyone involved in it, especially the patients. She should be able to report on the specific kinds of problems transporters encounter on a daily basis. Dan, as head of the transport department, is well positioned to explain how the transportation system is organized. Fred, his boss, can relate transport to other support services and have the authority to commit resources and support changes recommended by the team. Grace manages several nursing units and has extensive experience with the service provided by transporters, as has Maria, the head of the radiology department. At the project launch, team members were assured they could take the time required to accomplish their mission, approximately 8 hours a week for up to 6 months. In addition, they schedules the time, day, and location for each weekly team meeting. Questions: do you think the team composition is appropriate? What changes, if any, would you make and why? What do you think the team should do first? Verify the mission. At the first meeting of the team, confusion reigned. What did the Quality Improvement Committee mean by significantly reducing complaints? From whom? About what? Maria and Grace agreed that the transportation system has serious problems. Grace complained, "Everybody knows our transporters have 2 speeds, slow and slower." Sally claimed the system was slow because patients were never ready, and the transporters had to go back several times for the same patient. Dan blamed the problem on nurses who stole and hid wheelchairs, preventing his people from finding them when they need them. Maria said that she had collected a week's worth of data that showed patients waited an average of 1 hour in her department before being picked up by a transporter. Dan disagreed, indicating that no one waited longer than a half hour. The team was not fully comfortable with the mission statement received from the Quality Improvement Committee and decided to verify the problem before taking any action. They defined the transport time as the time interval from call for service to delivery of the patient. To everyone's surprise, there seemed to be no one who had this type of data. Further, there seemed to be no way to get it. Joe suggested that they could collect a sample of trips. Nursing and ancillary clerks could use a lookbook to track times by patient, transporter, ordering department, destination department, time of day, and day of week that orders were placed, times that transporters arrived, and times that patients arrived. The team adjourned for the day. Questions. Is this a good quality improvement project? Why or why not? What are the symptoms of the problem? How did or could the team measure the symptoms? Do any terms require operational definitions? If so, how would you define them? What should the next step be? At next meeting, a test period of 1 week was established and the log was designed to collect the data, and the data were collected and displayed in this chart. Analyze the symptoms. The team received the results of their data collection and concluded that there was a clear problem. Based on their own experience and the data, they proposed the following revised mission statement. Reduce significantly the number of patient transport trips that take longer than 20 minutes from the time the request is placed until the patient arrives at the proper destination. The team confirmed with the quality committee that the revised mission was consistent with its intent and would be more appropriate. At the next meeting, the team began to analyze the symptoms of the problem. After opening the meeting, Dan initiated the first agenda item for the day. Prepare a high-level flow diagram. Dan, at this point, we know we have a real problem on our hands, and we are clear about our mission. Let's see if we can get to the root cause or causes of our problem by studying the procedure we have been using to transport patients. Joe, Would you care to outline the process from your perspective? Dan, sure. Typically, a request is phoned into my department. My chief supervisor takes the call, makes note on the request, and calls the operator, who then pages a transporter. As soon as a transporter responds to the page, my supervisor sends him or her to the requesting department. Maria, excuse me, Dan. You make it sound like the supervisor is always around. Half the time, I get his answering machine, which leaves me with two choices. I can keep the patient in radiology until your supervisor gets around to call me, which could be next week. Or I can call the operator to have a transporter paged. I don't think I should have to do either. Dan, I don't think you understand what I have to deal with. I don't have enough stuff for starters, and somebody always calling in sick. If the supervisor has to leave his desk from time to time, it's understandable. Besides, I understand he returns most calls within 10 minutes. Joe, so there is an answering machine to take calls when the supervisor is away from his desk. Then, right, the next step is we send a transporter to the department that made the request. The transporter puts the patient in a wheelchair and takes him or her to wherever appropriate. As I have said before, my people could be a lot faster if they didn't have to hunt around for wheelchairs. Grace, even if your people never had to look around for wheelchairs, your service would be too slow. Sally, what Dan says about having to look around for wheelchair is true. It slows us down. But Grace, you should be aware of the fact that we are often delayed because patients aren't ready to be transported when we arrive to pick them up. Sometimes I have to wait for 10 minutes before they are ready. And there have been times when I have made several trips to pick up the same patient before he or she was ready to go. And that's not all. When they are finally ready to go, I have a heck of a time finding someone to help me lift them into the wheelchair. The elevators around this place take forever, and every now and then the place I am told to take a patient turns out to be the wrong place. Joe, okay, we can get back to this later. For now, let's concentrate on the steps in our process. What happens if the patient cannot be transported by wheelchair? Then the transporter would have to get a gurney. Joe, from where? Then from our department. Joe, okay, so the transporter typically doesn't know for sure whether a gurney is needed until he or she sees the patient to be transported. How about if IV, oxygen, or other special equipment is needed? Then, that's right. Often we are not told what really needed. Then we must go change or add equipment that can take 15 minutes or longer. The discussion continued and the team produced the following flow diagram. The unusual swirling symbols represented for a black hole. They were not sure what happened at that point. At the close of the meeting, the team reviewed their flow diagram and decided they should try to find the vital few parts of the problem. Maria volunteered to work with management systems to prepare a Pareto diagram from the data that the team had collected earlier. At the next meeting, the team reviewed the result. It's reproduced as shown in this Pareto diagram. This Pareto diagram compares the time taken to transport patients from different departments. Questions? What do you conclude from an analysis of the flow diagram and Pareto diagram? What would you do next? At first, the team members were disappointed when they saw the Pareto diagram. There were no obvious vital few categories. Joe reminded them that it often takes more than one try to find the right variable that will separate out the vital few. Then he asked them to suggest other possible variables for a Pareto diagram. They began suggesting other possibilities such as time of day, the transporter, the type of equipment needed, etc. In a couple of minutes, however, Maria spoke up. Look back at our Pareto diagram. The 5 ordering departments with the longest time are the ancillary departments in the study. The vital few are the ancillary departments. The team talked about this insight for a minute and agreed that their project should focus on requests placed by ancillary departments. With their project narrowed and a flow chart posted on the wall, the team brainstormed possible causes for long turnaround times until the end of the meeting. At the next meeting, they used these theories to construct the cause-effect diagram. In this cause-effect diagram, we defined our problem as the slow turnaround time and our categories of causes put as different stages of transportation process. From time transporter received order to time patient picked up. From time request was made to time transporter received order. From time patient picked up to delivery of patient to destination. Questions. Do you agree with the team's decision to focus on trips ordered by ancillary departments? Why or why not? Would you add anything to the cause-effect diagram? If so, what? What would you do next? The team decided to test the theories on each of 3 main branches of its cause-effect diagram as a unit. Since each branch of the cause-effect diagram related to one major step in the process, the team created histograms of the elapsed time for each step using the data they had already collected. Those histograms follow. The time from placement of the order until receipt of the assignment was highly variable and long for such a simple activity. The flat histogram suggested the presence of multiple processes. The time from receipt of assignment until the trip begins was also highly variable and could be surprisingly long. There was a difference here. There were two peaks in the distribution, one at 6 to 10 minutes and the other at 16 to 20 minutes, suggesting that there were two processes at work here, one which took about 10 minutes longer than the other. The time from beginning of the trip until final arrival had a few cases that were relatively long, but about 2/3 of the trips took less than 10 minutes, which seemed reasonable to the team. Those few with long time might need to be looked at later, but they were not the primary cause of overall delays. The team also examined the time from the request until the assignment is made. The histogram was certainly consistent with multiple paths, which the process could follow. These paths might be call answered or sent to answering machine, whether or when the answering machine was accessed, how many paging were required, whether a transporter was available. The team believed that the absence of a single process to receive requests and assign them to specific transporters was probably a major factor in delays, but they couldn't rule out the possibility that understaffing or extensive absences might cause either chronic or sporadic shortages of transporters, which in turn might be a major cause of delay. To test these theories about shortages and absences, they used the data they had already collected to compute the elapsed time for transporters from the time they delivered their patients until they received their next assignment. The results are on the following chart. Elapsed time across the lunch hour is excluded. By looking at the cases with 16 to 20 minutes between trips, the team identified that more than half of these occurred at times when transporters scheduled breaks. The big finding for the team was that there were many cases in which the time between trips was longer than 5 minutes. Even excluding the break times, many trips were separated by more than 10 minutes and even more than 15 minutes. Because transporters often waited so long, transporter availability was not the primary problem. If a shortage of transporters or absences had been the primary problem, then there would have been very few long waits by the transporters. The team now knew that The process for assigning a transporter took an unnecessarily long time. This delay was not the result of a shortage of transporters. The flat long distribution of times made it clear that there were multiple non-standard processes at work. For most of the team, that was enough a root cause. They needed a standard process for contacting and assigning transporters. Dan, however, said that he would feel better about this diagnosis if he had a little more data to demonstrate actual variations in processes for assigning the transporters. He said we would work with his supervisors and the telephone supervisor to figure out how often each variation of the process was used to assign the transporter. At the next meeting, Dan presented the following data based on 3 days of activity during the previous week. In this table, representing the type of ordering contact and the percent of assignments, direct telephone conversation with transportation supervisor 82%, message left on answering machine 17%, ordering department calls operator directly 9%, transporter in department and receives assignment personally 15%, transporter talks directly with supervisor on telephone 48%, transporter gets assignment from operator 27%, transporter gets assignment from another transporter 14%, transporter calls and gets answering machine 10%, more than one paging call required until a transporter responds 80%. One thing that Dan's data uncovered was that there were even more variations in how assignments were received than the team had originally identified. In many cases, the assignment was being relayed by the operator or by another transporter. One cause was now clear to all. There were too many ways in which transporters receive their assignments. A single systematic process was required. But the team knew from its histograms that even the most efficient assignment process would not solve enough of the problem. They needed to look at the theories for delays from the time the transporter received the assignment until the patient trip began. They had no data at hand to test any of these theories, so they developed a data sheet which the transporters would use for a week. The sheet was simple enough that all the transporters saw no problem in using it. In this sheet, there were instructions for use, then a place for the transporter name, time receive assignments, and where patient picked up. Then the transporter have to tick one or more of the following conditions: patient not ready, patient not there, had trouble finding needed equipments, arrive without some or all of the right equipments, delay in getting assistance to lifting patient, unusually long wait for elevators, other significant problems specify, then or no significant problem. At the end of the week, 47% of the trips had reported one or more problems. This Pareto diagram summarizes the problems experienced by those trips. Needed equipment. Patient not ready. Patient not there. Delay with assistant lifting. Trouble finding patients. Elevators, and so on. The team immediately noted that by far the most common reasons for delay was arriving without the appropriate equipment. The team discussed why this might be so. Theories included: the transporter supervisor does not pass on all the proper information, or the transporter cannot find the equipment, or the ordering department omits some of the special needed information, or the transporter forgets what to bring. Grace, the nurse manager, said she doubted that the nursing units would omit mentioning special transporter needs that often. But Maria, from her experience in radiology, speculated that the receptionist in radiology may not know about special needs when she called to request a transporter. Fred noted that Maria's theory would be consistent with the team's decision to focus on causes related to orders placed by ancillary departments. He presented the following results at the next meeting. As shown, the problems are too much obvious in ancillary departments than nursing departments. The picture began to fall in place. When ancillary departments order transport, they were less likely to be aware of special patient needs. They were probably also more likely to order transport without being aware whether the patient was in the room and ready to go. After further discussion and checking with some of the ancillary department staff who ordered transport, the team decided it had identified the two root causes of delays in patient transport. One, ancillary departments ordering transport are frequently unaware of special patient transport needs. Two, the multiple undefined processes for locating an available transporter and making an assignment are unreliable and unpredictable. Questions: what are the strengths of the team's approach to testing theories? Are there any weaknesses? Had the team found a root cause? If not, what else must it do? What should be the team's next step? The team brainstormed a variety of remedies. It was clear that no one remedy would fix both root causes. So the team considered the remedies for each root cause separately. The team looked first at the remedies to address the delays in making assignments. After some discussion, they agreed that, as part of the remedy, they would install a small metal board in the transport office with the floor plan of the hospital on it. They would then use small colored magnets with each transporter's name on two of them. One magnet would be placed on the origin of the transporter's trip and the other on the destination. This procedure would be easier and more reliable than the current paper and pencil notes. The magnets would also make it easier to spot the most likely candidate for a new assignment. They also agreed that when the shift supervisor was out of the office, the telephone would be covered by one of the following at all times: the department head, or the secretary in building services, which was located in a space next to the transport office, or the secretary for the assistant administrator responsible for transport, or one of the transporters. The team had a list of 9 proposed alternatives for actually contacting the transporters with a new assignment. They conducted a multi-vote on the list. The remaining 3 were: have transporters use the nearest telephone to inform the shift supervisor when they have completed an assignment, or give transporters pagers so the shift supervisor would request a call, or give transporters two-way radios to communicate with the shift supervisor. The team then agreed on the criteria to use in making their selection among the 3 alternatives. The team members agreed to spend time before the next meeting rating the 3 proposals by the criteria and bring their results to the next meeting. But they had no information on the cost of the proposals. So Dan offered to get some basic cost data for the next meeting, and team members would then spend the first 15 minutes of the next meeting completing the cost and benefit cost criteria. At the next meeting, Dan provided the following table. The team members were now able to complete their evaluations. The following table contains the most frequent rating, high, medium, or low, for each of the criteria for each option. The last line contains the arithmetic average of the individual rating. This table shows that the average summary for phones was 3, for pagers was 1.7, and for radios 1.3. In discussing these results, the team discovered that the primary reason for the team differences on whether to adopt the pagers or the radios was the matter of cost. 2 of the team members really wanted to keep the cost of the project to a minimum. During the discussion, however, they agreed that the slightly higher cost was worth it because the radio would ensure instant response rather than having to wait for the transporter to find a telephone. The team readily reached consensus that the two-way radios were the best alternative for this part of the remedy. Questions. What do you think of the team's approach to evaluating remedies? What are the strengths? What are the weaknesses? What are the next steps? As you will recall, The team's remedy to address the delay in assigning a transporter had three components. 1. Install a tracking board with assignment magnets for each transporter. 2. Ensure that when the shift supervisor must be out of the office, telephones would be covered either by the department head, a secretary in another department, or one of the transporters. 3. Provide two-way radios to reach the transporters with new assignments. To address the problem of arriving without the proper equipment, the team decided that they would do the following things. Replace the space on the dispatch sheet that asks for special needs with a checklist of the most common requirements. And provide both the transporters and the ordering departments with the same checklist. When the shift supervisor receives the request, he or she would go down the checklist and ask each question much as a pilot would before takeoff. The transporter would also make the same item-by-item check when given the assignment. To help the transmission to the new procedures, the team developed the following flow diagram. In this flow diagram, ordering department calls for transport. If the supervisor is in his office, he will complete the checklist and identify closest available transporter. If he is not in his office, phone roll over to backup, who will complete the checklist and give it to the supervisor on return. Then the supervisor radio transporter, complete checklist with him, update tracking board and create transport record. Then transporter gets equipment, transport patient, and the transporter radio back the supervisor. Supervisor updates tracking board and transport records. As we notice in this flow chart, we have documents like the checklist and the transport record and updating of the tracking board. Comparing this with the last flow diagram, we could detect the improvement achieved by the team. The transporters, their shift supervisors, and the secretaries who would provide backup answering were introduced to the new design in a short meeting. They were asked for any problems they saw with the new approach and given a chance to ask questions. The team then made a few minor modifications. Next, a member of the team visited each department that ordered transport, giving them the new checklist, answering their questions, and identifying any issues they might have with the change. The only issue that arose in the early conversations was that some saw the checklist as a more bureaucracy and paperwork, a duplication of what they already did. To deal with that concern, later conversations emphasized that the checklist was not a report that had to be filled. It was a job aid and a description of the questions that the transport department would be asking. Accurate information was needed to transport the patient quickly and safely. Ordering departments could adopt their own approach to obtain the information, just so long as they were able to answer the questions accurately. Finally, before the new process was implemented, the transporters, supervisors, and the backup secretaries received a short training session that gave them opportunities to practice and role-play the new process. During the first 2 weeks of implementation, one of the team members collected the transport record each day and constructed a histogram of the total time from the order being placed until the patient was delivered. If there were any long times that suggest possible problems with implementation, Dan would investigate these. The only significant problem that occurred was that transporters were not used to calling in on the radios as soon as they were finished with a job. But the new radios enabled the supervisor to call any who had been out a long time. These calls would uncover any problem the transporters were having, like waiting for patients, and also remind them to call in. This is the histogram for total elapsed time for the second week, which shows that most of the trips finished in 11 to 20 minutes. This shows the great achievement done by this improvement team. Questions. Assess the team's approach to design the remedies. What are the strengths? What are the weaknesses? Would your approach differ? If so, how? Did the team address possible resistance to change? Did the team successfully prove the effectiveness of the remedies? What steps should the team take next? Hold the gains. The transporter record contained the basic time and other data on each trip, so it would be possible to calculate the elapsed time for each trip and construct a control chart, but that was a lot of work. The time and the energy required would be substantial. They decided to take a sample of 15 trips from each shift and construct a control chart reporting the percent of samples taking longer than 20 minutes. This approach of sampling and using the simple control chart could be completed by each shift supervisor in about 10 minutes at the end of each shift. This was extra work, but it was important to ensure that the gains were held. Besides, if the process were kept on control, there would be fewer complaints to deal with. If the control chart indicated that the times were out of control, the supervisors were to identify any causes for that condition. If the supervisors could not identify or remove the problem, then they were to discuss the matter immediately with the department head. The full set of transport records and checklists would provide an adequate database to review the factors that might have caused the out-of-control conditions. In addition, at the end of the month, the department head would create a summary of the daily shift reports as one of the quality indicators presented to the Quality Council. Questions. Do you think the team put in place adequate controls to hold the gains? If not, what would you do differently? Can you think of any way that the team or the operating departments might foolproof the remedies better? Is there adequate provision for audit of controls? Is there anything else that the team should do? If so, what? Thank you.